Sohail Husain's career is really spanned working as a pediatric gastroenterologist, physician, scientist specifically, as starting at Yale, then the University of Pittsburgh, and now he currently resides in Stanford. He's the chief of the Division of Pediatric Gastroenterology. He also serves as the chair as our pediatric NASPIG and Pancreas Committee, and as a counselor on the AGA Pancreatic Disorders section. Outside of the leadership roles, he does have a lot of developed expertise in molecular pathogenesis and translational research of pancreatitis. And his most recent endeavors are in exocrine pancreatitis, and is involved with lots of clinical and translational work throughout the field. So we're really happy to have you as our guest speaker. And it's a topic we've been talking about as a group because the group does include pediatric and adult trainees. And so trying to figure out how to really bridge the gap between the two of us and blend research and kind of expand the field for the communities.
Great. Well, thank you for that introduction. This is informal, I think, because let's see, we've got 12 participants on the call. And so feel free to interject. I won't be looking at the chat just because I've got to look at the slides. But you're welcome to put something in the chat and we can address it towards the end, or you can just interject or raise your hand because I can actually see hands go up on the participant section. So with that, I wanted to spend the next few minutes. I know the sort of format is to keep the presentation part rather brief. I was asked to talk about the differences between pediatric and adult pancreatitis. And I think there are several differences, many similarities. The differences are actually what offer unique opportunities for further research, as I'll explain. What I'll also do is tell briefly about me, my research interests, and I'd like to end with just some thoughts on how to excel as an academic physician. Oops, sorry, and let me share the screen with you. Do you see, okay, so are you able to see the PowerPoint? Okay, great.
Yep, works well.
Wonderful. So I'm a physician scientist. I spend most of my time thinking about science and medicine from investigation. I'm by clinical practice a pediatric gastroenterologist, and as you know, I wouldn't be here if my interests weren't pancreas. Just to tell you about sort of the types of experiences that shape who we are. I'm an immigrant from India. I arrived at the shores of Brooklyn, New York when I was 5 or 6 years old with my family. Grew up there, went to college in upstate New York, Boston for medical school, and residency in New York City at Bellevue Hospital. And then I had the chance to do fellowship in pediatric GI at Yale, and I spent a total of 10 years there. After that, I went to the University of Pittsburgh, where I spent 8 years. And just about a year ago, I moved to Stanford, and I did this to become a matchmaker. That is to marry science and medicine. And I think that it's really a wonderful opportunity for each of us to meld in some way, shape, or form science and medicine in our daily and regular activities. My lab focuses on 3 areas. The first is the pathways that transduce pancreatitis, and specifically the calcium-mediated pathways involving the calcium-activated phosphatase calcineurin. Second area of interest is how the pancreas recovers after injury. And the third are specialty forms of pancreatitis. I'll tell you why I got involved in this as a pediatrician, and specifically drug-induced pancreatitis. As an acknowledgement, much of the data I'll show you come from the Nspire pediatric pancreatitis cohort, and many of the points that I will raise have emerged from discussions in the Pancreas Committee of NASPGHAN, and my ability to spend the time here is in thinking about these problems is due to funding from the NIH and NIDDK. And I just want to impress the importance of being part of a network, being part of committees that are focused on the areas of relevance to you. So, don't go into like a committee on toenail regeneration if you're thinking about pancreatology, but do think about pancreas committees, etc. So differences and similarities. The first big similarity is the definition of acute pancreatitis and chronic pancreatitis in children, and the severity classification. The Nspire group came out with definitions which were identical to the revised Atlanta criteria. And what is the difference then? Well, I think the use of age-based criteria for defining the inflammatory response, organ dysfunction would be different. Otherwise, it's very similar. Why is that important? Well, it turns out that there are pediatric groups that use definitions that are archaic, and they are the pediatric cancer groups, for example, that have grading systems that are based on the height of the pancreatic enzymes. As a pancreatologist, we would think that that does not have relevance. So it's important, it was important for us to standardize our definitions. The typical presenting clinical features of acute pancreatitis are different between adults and infants and toddlers. And that's shown in this table where abdominal pain and broadly speaking irritability in that category was seen in only about 40% of infants and toddlers compared to 93% of adults and teenagers. Epigastric pain and tenderness in only about 60% versus just under 90%, and nausea, vomiting in only about a third of infants and toddlers versus more than 2/3 of the older age. And these were data that came from a resident and a medical student at Yale when I was there, I think in 2008, 2009, and we had scoured something like around 500 records and put together observations because I really wanted to understand the clinical problem. I figured the easiest way was to just go into your backyard and learn about the problem. What we also learned was that the amylase is a poor marker for acute pancreatitis, especially in infants and toddlers. And so similar to adults, but here it's more accentuated. And what's shown in the red box is how the amylase performs compared to the lipase, especially in infants and toddlers, where it's very poor. Part of the reason why infants and toddlers don't manifest an elevation in the amylase is shown in the right. Compare the serum immunoreactive trypsinogen as a marker of, as a surrogate marker of pancreatic enzymes. So what's in the blood might be similar to the relative amount in the pancreas. And you can see that the serum IRT is, sorry, you can see my pointer here. The serum IRT is above the lower reference limit at every age, whereas the amylase is low physiologically in normal infants and toddlers, and it really rises to adult levels for about a year of age.
Can I ask you a question?
Please.
So just really out of curiosity, um, so for infants and toddlers, what do you use as the gold standard of pancreatitis? Do you do a CT scan or ultrasound to look for inflammation, or what's the gold standard?
Yeah, I mean, most people would use the lipase. So in that case, the lipase is actually a pretty good predictor of pancreatitis.
Hmm.
But imaging certainly is important, especially since the classical clinical symptoms are not easily manifest. It's a good question. About the epidemiology of pancreatitis, these are data from Zach Sellers and senior author K.T. Park, both of whom are at Stanford. And they just looked at large insurance databases and confirmed what had been shown previously for adults, which is that the incidence is about 111 per, I think the denominator is 100,000, and the prevalence of chronic pancreatitis is about 24. And if you look at children, what they found was that roughly, so if you had to sort of remember this, about 1/10 the incidence and prevalence of acute pancreatitis and chronic pancreatitis, respectively. What they also showed is that in both age groups, the trends for the incidence of acute pancreatitis have really stabilized. About 15 years ago, there seemed to be an increase in the number of cases, and over the last, and what they're showing is from 2007 to 2014, last 10 years, the trends have roughly stabilized. And it's not clear why they increased and why they stabilized, but those are the empiric data. What's really interesting about children is that whereas in adults, the etiologies of pancreatitis are primarily first biliary tract disease and alcohol, and then there's a squished in the pie, the rest. In children, the etiologies are much more proportionally varied. And biliary tract disease is still the #1 reason, followed by, however, medications, which makes up about 1/5 of the pie. And then there are systemic causes, trauma, viral etiologies, metabolic, and other. And the idiopathic has been largely closing in based on genetic associations.
I have another question. Sorry.
Yeah, definitely.
So, attributing a cause of pancreatitis to medication, I find very challenging in adults. Is it any easier in children? And how, if so, how do you attribute a cause? And this may be included in your talk about your research, but I'm just curious how that's determined usually.
Great question. That's something that we're grappling. So if you look at the definitions of drug-induced pancreatitis in adults, it's primarily after you've excluded other causes. And even if the drug is known to cause pancreatitis. And the pediatricians, and I will say that our group probably is responsible, so you can blame us for this, which is that what we did was we took a different approach, and we said that, and this was based on our experimental evidence, some of the evidence from translational studies, that pancreatitis is really the conglomerate, the aggregate of multiple risk factors. And sure, you can have gallstones, right, as a cause, but you wonder why. I mean, have you ever thought about why not every distal impacted gallstone leads to pancreatitis? Why is it that only a certain percentage, maybe, based on some circumstantial evidence, something like 10%, 20% or so, is it just because it isn't in the right area to cause obstructive pancreatitis? Or is it that obstructive pancreatitis obstruction doesn't always lead to pancreatitis? that you
Yep.
need additional risk factors. And so
Right.
if you take that approach where a medication is considered associated at the very least, if not a reason for induction of pancreatitis, in addition to other factors, then you actually turn out to have more cases. And that's probably the main reason for the difference. But there is another, and it is that when you look at the drugs associated with pancreatitis in children, and these are studies from Harrison Bai, who was a medical student at Yale at the time, in our lab, and it was that many of the drugs that are associated with pancreatitis are in the pediatric space. And they include, for example, valproic acid, which is given for pediatric epilepsy, or asparaginase, a drug given for ALL, which is primarily a pediatric tumor. And when you take that approach of having multiple possible etiologies or risk factors, we found that 1/3 of children with drug-associated pancreatitis have concomitant etiologies. And this was really interesting, worth investigation, because some of these etiologies that are concomitant are systemic, some are hypertriglyceridemia, biliary tract, so gallstones, as I was referring to, and viral. And it would be curious to understand how the drugs on top of these other factors predispose to the emergence of the problem. It also begs more questions. Why do some drugs cause pancreatitis? And why do only some patients develop the problem with exposure to those drugs? And can we identify those patients who are at risk for those drugs before they receive the drugs, and thus prevent the pancreatitis or provide a rescue therapy for the problem? Oncologists are always thinking about that. So if you take an ifosfamide, develop neurotoxicity, you take methylene blue, you're always thinking about how to avert the toxicity. Should we be doing the same thing? And so there are some really pressing questions in the field. Part of my talk is just to get you excited about the questions that really need to be answered. And there are many more. One of them is why a drug like asparaginase causes pancreatitis in about 5 to 10% of users. Why do 1/3 of these patients develop severe pancreatitis, much more than other etiologies? And why do 1/4 of them develop pseudocysts? And can we model that in experimental conditions to understand the problem?
So not necrotizing phenotype, but pseudocysts.
1/4 develop pseudocysts. The number that develop necrotizing pancreatitis is probably somewhere around 10%, so much higher than
Wow.
other etiologies.
Wow.
In fact, most people will remember. So I remember my worst case of pancreatitis was necrotizing pancreatitis from asparaginase. Well, the gap in idiopathic pediatric pancreatitis has been filled to some extent by the emergence of genetic risk factors. And here are 4 that come out of the Nspire group, and in comparison to the NAPS2. And this is a paper in the Journal of Pediatric Gastroenterology and Nutrition from last year, from the Inspire and NAPS2 group. And they show that genetic factors are more common in children when you look for them. And as you can see, PRSS1, SPINK1, CFTR, CTRC are all much more common. There's a caution, though, about how these registries come about. So the proportionality may be due to ascertainment referral bias. This is not to say that more children have PRSS1 in general. It's just based on those cohorts from those referral centers. And so what is a big difference between children and adults? That genetic risk factors are enriched in children. And that's shown in this schematic, where the influence of genes is much greater than the influence of the environment and toxins in children than in adults. I think that's an opportunity, because if you're thinking about studying genetics, or sometimes even structural problems that haven't had the influence of years of scarring or change, children are the ideal group to study. And in terms of structural risk factors, I think there's an opportunity. Pancreativism is a controversial risk factor for pancreatitis. It's highly prevalent in the general population. In one study from the Nspire group from a couple of years ago, 15% of the cohorts of acute, recurrent, and chronic pancreatitis had pancreativism. So is it really a risk factor? Well, there is an adult SHARP study. This really begs the question of a pediatric SHARP study without all the influence of environmental factors of years or scarring. And then in children, we often think about annular pancreas, a common channel, colodocal cysts, which present usually around 3 to 5 years of age, as sometimes presenting with pancreatitis. Infections are really exciting, because it's really the pediatric reports that have put infections on the map as a risk factor for pancreatitis. And there are a whole slew of them, including mumps, influenza, hepatitis, herpes, rotavirus, salmonella, even parasites such as ascaris. Why do they cause pancreatitis? What is the pancreatrophic specificity of the strain of pathogen? And what is it about the host? And these are questions that can be answered in clinical and experimental settings, and not something that's ever been really probed in a systematic way. Mortality is lower in children. Severe acute pancreatitis occurs in less than 10%, and mortality less than 3% overall. And moderately severe pancreatitis about the same, 20%, but it depends how you define it. And in this study from Maisam Abu al-Hajjah's group in Cincinnati, they defined moderately severe acute pancreatitis as any patient who went to the ICU. So you can imagine how subjective that is. But I do think that overall, children are much less severely affected. But that gives us an opportunity to focus on non-mortality issues, because remember, pain, length of stay, recurrence of pancreatitis are major problems that patients suffer from. It's not just death that we should be thinking about. Calcifications and endocrine insufficiency is less common in children with chronic pancreatitis, as you can see from this table, where it's 15% in children compared to 57% in the adult cohorts from NAPS2. Endocrine insufficiency only less than 5% versus a third of adults. And this may be because children manifest early signs. They haven't aged enough to develop the destruction of the pancreas. It's also possible because we often rely upon MR imaging compared to CT for diagnosing chronic pancreatitis. You might miss small calcifications on MR. I think it just emphasizes the differences between children and adults in terms of the manifestations and diagnostic features of chronic pancreatitis. Well, children do better in outcomes for total pancreatectomy, islet autotransplantation. You can see that in this graph where the insulin independence is much more sustainable in a larger number of patients compared to the adults, in whom only about a fifth have achieve insulin independence by 3 years of age. How long this will last and whether there's a downturn is not clear. But we can at least say in the short term that children do much better. And children have special needs. We're always thinking as pediatricians about growth and development. And the changes that occur to their health as children have a lifelong impact to them as adults in linear growth, nutritional parameters, therefore psychosocial well-being. Pain is just as much as in adults and children. Children are often teased at school or by their peers for faking their pain. Adolescents are stigmatized as being drug seekers in a society that's increasingly heading towards making drugs much more commonly available. Providers may not recognize chronic pancreatitis in children just because they don't recognize it as much, and children may not manifest those classic symptoms. And it has impact on missed school, work days for their families, and fundamental, foundational learning opportunities. I think that, yeah, another area of further evaluation, because this is a real problem that needs to be studied more rigorously. Please.
So, in adult pancreatology, it's a never-ending debate as to how you diagnose chronic pancreatitis. Now, imagine with less severe phenotype in children, it may be even harder. Do you have in pediatric pancreatology? Do you have a different set of criteria for diagnosing chronic pancreatitis, or is it purely based on number of recurrent attacks of pancreatitis?
Yeah. So the definition in children from the Nspire group for chronic pancreatitis is very similar to the adults. It's a combination. In fact, there's some strict criteria on it's. I have to look back at the exact criterion, but it involves either the presence of endocrine or exocrine insufficiency, or the findings, imaging findings of calcifications, ductular abnormalities that are not just post-acute change, and the presence of chronic pain or the presence of chronic pain in that setting. And so it is controversial to some extent. By and large, the definitions are similar. The definitions for both are controversial at some point. So if I was to summarize the similarities and differences, the incidence in children and of acute pancreatitis and the prevalence of chronic pancreatitis are about 1/10 that of adults. The similarities for both adults and children are that the recent trends for incidence of acute pancreatitis is stable. The diagnostic features are problematic in infants and toddlers. And in children, there are fewer calcifications in chronic pancreatitis, and the severity is less or lower. And the risk factors in children are less alcohol, more drugs, more genes, more anomalies, and more infections. And there's a great impact on growth and development from these morbidities. And the treatment outcomes in children are better with TPIET for chronic pancreatitis. I think there are unique opportunities. As I mentioned, an enriched genetic population in children, fewer environmental confounders. Questions about why there's less severity. Are we just dealing with a healthier age group? Are there other fundamental reasons? Is there plasticity of the pancreas compared to adults? And there's some data to suggest that from autopsies where you look at, where you stain for proliferation markers. There are fewer in adult patients compared to children. And so is it a plasticity issue? Studying drug-induced pancreatitis in children because of the drugs that they're prescribed would be particularly interesting. And I would just add that major advantage of studying children is you've got highly invested advocates for them who are their parents and families. And they usually, once they're invested, will make clinical trials, translational studies much more likely to come to fruition than adult patients. I'd like to end by just giving a couple of slides of advice to trainees in pancreatology, GI, and junior faculty. As you've seen just from this talk, there are many exciting questions in our field. What I did when I started, and I continue to do, I keep a log of interesting questions. Start crystallizing those questions, and the ones that are pressing, and ask what you would like to tackle. Because without having a really stimulating question, it's difficult to wrap your head around the next steps of creating new knowledge. You should also know that medicine, and scientific medicine in particular, is a career-long journey. You can't do it all in a year. You can't don't think that in your fellowship you will have obtained all of the tools for as junior faculty. It's really lifelong, and you're constantly retooling. And I think the academic physician who does well can adapt to new tools, new questions, or the same questions with new tools. And so it's important to take breaks, smell the flowers, think about your accomplishments, because we're often thinking about what we need to do to get to the next step. But we're not thinking about what we've accomplished thus far. And build those relationships. And that really brings me to the last point. The people you will work with are more valuable than the projects that they're involved in. And you'll often hear from PIs, your mentors, and others about getting a project accomplished because your academic year's ending, or you've got to go for promotions, or that's or the fellowship's ending. And that's really the way our academic cycle stimulates one another. But remember that those projects will end, but the people you will work with will go beyond that, and for many projects, and perhaps for a whole career lifetime. And so cultivate those relationships because that will carry you much further. And the last point is, it takes a village to raise an academic physician or physician scientist. And so seek out mentors. And what I've shown in this photo is my mentor, Fred Gorlick, who was kind enough to take me into his lab when I was a fellow. And I spent 2 years during my fellowship with him. And then I think another 2 years in his lab before I started my own lab. And even when I had my own lab, I'd spend, 1 hour every week with him and a co-mentor, Mike Nathanson, to go over how things were moving forward in my lab for another 4 or 5 years. It was only until I moved to Pittsburgh that I cut the cord. But it takes that amount of time. It takes really having a mentor who cares, like Fred did. But have multiple mentors. It's not just one. Have multiple sponsors, people who aren't exactly up close with you, but who are interested in advancing your career. Have coaches, people who can tell you what you're doing well, and more importantly, what you could do better, and who are like a mirror to let you know how you look without all the pretensions. Put together development committees. And for example, in our division, the expectation is that every junior faculty member will have a faculty development committee that consists of their career interests. And this is the fun part. You're in like a very elite situation that many people in the world would only dream of. And so dream about doing things that are great. Aspire to moving the field as much as you are moving your career. And along the way, get reality checks. Put together those timelines and project forms and milestones, and know that you also have to have some product in the end. But it's this ability for us to aspire that really makes it a lot of fun in science and medicine. And with that, I'm open to any comments or questions.
Thank you very much, Dr. Husain. That was a really, really great presentation. And I think your goal of getting us all like motivated and giving us questions that we can tackle as a group, I think was definitely achieved. I do have a question, more of just kind of thinking long-term, things that we can as a group really be meaningful and tackle to help our patients is, when you show that slide about the incidence of, the etiology of pediatrics being so wide-based as compared to adults, I imagine it as like, as time goes on and, those genetics play into this and different risk factors play into it, it's almost like a funneling down into a much smaller etiology that happens in adult pancreatitis. And where in that timeline can you identify risks or identify certain things that we as pediatricians can maybe find to give a better prognosis? And I know that's a big kind of order to fill, but thinking about the different, the worlds of our databases these days is Nspire has a huge database. The Apprentice and Apprentice 2 is even larger too. How, and I don't know if you've thought of this, but how to meld these databases and tapping into these trainee groups to really participate and be a part of that too, I think is something that we're somewhat itching to be a part of. But I wonder what your thoughts were on that.
Totally. These consortia, many of them are NIH funded. And so by the rules of the NIH, there has to be some level of inclusion. And so centers can apply, individuals can reach out. If there's a project that you have in mind, you can go through a formal process. I think the easiest way to get connected is firstly to be part of that local center that's a site for these groups. If you're not part of that and you want to tap into them, then there's that earlier process. As far as being able to interrogate data, I mean, what I'm recognizing now more than before is that just like we did when we were at Yale, it was that you've got a backyard in the U.S. Most universities have access to big data, and if you don't have access to it, it's not as expensive as you might think to purchase some of those data. You have to have the tools though, and so big data is really hot right now. And so if you've got the willpower to spend a few days in crash courses on R, and SPSS and other statistical software to partner with people in your institution, that might be one way to data mine. We're interested in data mining a large insurance data set for drugs that are associated with pancreatitis. We'll see what we come up with, but there's multiple ways to get involved with patient-related information.
I have a question, Sohail. I mean, it's great to have you because not just from pediatrics perspective, but also you are well known in the adult community, adult pancreatology community, and I see you talking, with all other leaders in the field, and we are as a training group trying to see how we can close the gap between, or maybe at least make the bridge better among trainees who are pretty much pediatrics or study the adult pancreas problems. So, and I think Paul is doing a project right now, mainly working with Chris, something more tailored to needs in the pediatric community. But what else do you have in mind or would suggest as strategies to develop for us where we can join forces with both our colleagues in the pediatric field, also in the adult pancreatology, in terms of junior faculty and trainees? I think you pointed out data mining. Actually, I think that could be something really good we can do, join the efforts together. But do you have anything else in mind that you would suggest as a strategy or maybe an area of interest?
Oh, great question. A question that I think we all need to ask is, how do you make a convincing argument that you yourself will believe as an answer to a question that you posed? And that's what brings studies to higher impact. And so if there is, firstly, a clinical question, so your question is, how do you meld pediatric, adult, and joint forces work together? Well, I think there are multiple interesting questions in children, some of which I've posed, and to then for anyone, adult or pediatric or non-clinician, to take them to the level of testing certainly elevates the impact of the findings. And so you go beyond association into actually causal evidence. That's one. In terms of, and so, for example, drug-induced pancreatitis. I mean, I think it's such a hot area, one that really begs a lot more work. And there's so many drugs, and imagine doing something that's better than the drug-induced liver injury network, where you're able to data mine the FAERS database. And just think about like all the possibilities. So you go into the FDA FAERS database and using informatics, if you're able to data mine it in a way that establishes strength of association and then goes beyond by helping with causality using algorithms, and you're dealing with hundreds of thousands of feed data, that's value added. So bringing in people that and partnering with others who are in fields that are other than our own, I think be very helpful. So I think making a more holistic approach to questions, whether they're in children or adults, is probably much more fruitful. In terms of trials and so on, the reality is that it's harder to get a pediatric trial off the ground because children are a special population. There are commercial factors such as the market number of people in the market, number of patients in the market. And adults usually have more patients. They're easier to get through an IRB to start with, although most clinical trials do have some justification of why, required justification of why you're not including children. So I think it depends on the question. So that's why I think like pancreativism, it might be a better question answered in children than in adults. Whereas post-ERCP pancreatitis interventions would be easier to do in children, easier to do in adults than in children. I guess it just depends on the context.
Dr. Hussain, thank you again for speaking at our forum. My question to you is more personal to you. You have been incredibly productive with your research and all your track record for grants. And for those who do not know you, your grant track record, in your 15 years since you have finished your training, you got at least 4 or 5 R01 grants, right? So this is incredibly productive. And briefly, do you have any words of wisdom for the trainees, like how to secure grants and how to get funding for your research?
Well, thanks for the comment, WinCat. I think WinCat can attest to the advice that I'm going to give. And Lee's on the call, I see, and she can also attest to this, which is have goals. And I don't think I'm there. I think I've just started. So, you know, I'm sort of hopefully just on the start. It's that have goals for yourself and be persistent. If you know that what you plan to do is important to you, important to society, and is worth the time and effort, then stick to it. We had a Department of Defense grant, Lee can attest to this, that we thought about year one, put in a pre-application, didn't go for the full because just at the last minute we felt like it just couldn't happen. And the next year we went for it, we wrote it. It was a struggle to figure out how to write this, like bear of an application, and we didn't get it. But we just kept going, and we said, well, we'll just try it again. If after this, maybe we won't do it, but or maybe one more time. But then we were able to get it after the third time. And you know, you look at the last application versus the original application that we submitted in year two. They're very different because we learned along the way a lot of things. So I guess another piece of advice, so be persistent. Second is think of feedback as a gift. Not everyone can take feedback well. And it's tough because, you know, it's tough to get slashed on grants. It's tough to get your paper rejected. It's tough to not get the job, or to have the IRB tell you to put it back in again and again and again. And there's sort of this process of attrition as well. But think of every piece of feedback as a gift that you're receiving from someone who really does want you to succeed, and is giving you free advice about that. And many companies will pay thousands of dollars for consulting advice. You're getting it for free. It's just you're getting it the painful way. I think the third is, you know, the reality is that like more than half my grants aren't funded that I've applied for, more than half the papers, or more than half, like Lee, I think something like 75% of our papers are rejected, but we just keep putting them back in. And you know, you have goals and you try to set them and stick with them. So where would I like to be in 10 years? And I'd like you to ask the same question. Think about your 3-year, 5-year, 10-year goals. What would you like to be doing if you could do it any way you'd like? And if it is worth doing, then how can you change what you're doing right now to reach those goals? What I'd like to do in 10 years, and that's why I sort of felt motivated to move. And it's not to tell you that you should move, but sometimes there are opportunities that you just have to latch onto. I'd like to, you know, be more involved in science and medicine and the marriage of the two in a way that's much more impactful. And each of us has goals that you set. So I think the third piece of advice is, so the first piece of advice was to be persistent. The second was to, what was the second piece of advice? Anyway, there was like 3 or 4 pieces of advice in there.
Feedback.
Yes, feedback, yes. Think of, don't let these rejections get to you. In fact, look at the feedback they give you. And the third is look at the bigger picture, and don't worry about all the rejections as a result.
Great, thank you so much again. We're coming close to 7 o'clock now. I just want to throw it out there if there's any other questions, comments you guys have.
Thank you so much for the brilliant and inspiring talk. Just thinking about the incidence of pancreatitis, how you mentioned that it's plateaued. Could it be that physicians were not as aware of pancreatitis as a cause of belly pain years ago, and so now that we're just recognizing it more, suspecting it more, and appreciating it more, that sort of explains the increase in incidence. So that's my number one question. Number two is, have there been efforts to follow these really well phenotyped patients into their adulthood to really study the impact of environmental factors, for example, and what that does to the pancreas later on? I would imagine just because of the migratory pattern of children, like, when they grow up, they go to different places. It's going to be incredibly hard logistically, but have there been efforts to define that?
Great questions. Yeah. So the first question was about why there was an increase at one point in the incidence and prevalence of acute and chronic pancreatitis. The second question was, are there any studies, or would it be possible to track whether children who moved from one environment to the other had a change in the incidence of pancreatitis? And that would be really interesting for like recurrent acute pancreatitis, where you've got a patient. So if you took a patient with acute recurrent pancreatitis, you moved them from Pittsburgh to Palo Alto, California, and they started having fewer cases of pancreatitis. Maybe it's the good weather or something like that. So I'm not aware of anything related to that for the second question, but it's certainly an interesting question. It's like the diet and outcomes of health between, for example, Asian children that move to the U.S. And so on. I think regarding the first question, I think it's a combination of factors, and I'll tell you that based on some of our data. I think testing is certainly a factor, and the group in Pittsburgh suggested that just based on some correlations of amylase testing and the incidence. We looked at that in our Yale cohort, and that certainly could explain a little bit of the difference in the increasing incidence that we saw. But the largest factor, and that too, by the way, was a modest difference. So I guess it depends on the institution. At Yale, there was really no increased testing that correlated with the increased incidence, commensurate to the number of overall patients that had increased in the hospital. I've seen many hospitals increasing their volumes. What we did find, though, was that there was a referral problem in that the ascertainment of incidence and prevalence was based on tertiary care centers reporting them. And there was a movement in pediatrics about 20 years ago to shift acute care from the community hospital to the tertiary care hospital. And so we're just getting more cases that would have just stayed in the community hospital setting. And so that sort of led to this bias in higher cases. I think it's a relatively moot point right now because it's stabilized. But it's an interesting question nonetheless of why it happened in the past.
Yeah, I was just thinking about Peter's question about those patients that have the pediatric ones that we do find genetic. mutation that could explain their chronic pancreatitis. Does Nspire, are they currently have a way to follow them into adulthood, or I'm not sure if it's part of their database, or if they stop at 19, they kind of no longer are able to track them, or how does that work?
Yeah, no, great question about longitudinal follow-up. The Inspire group is supposed to pass off to another group after the age of 19. I think there's a group, when I was at Pittsburgh, there's a study led by Diraj Yadav, and it's part of the CPDPC. I'm not sure if anyone's going to the CPDPC meeting tomorrow, but there's an acronym, I'm just blanking on it. But technically speaking, there should be some longitudinal follow-up of these Inspire patients, but the pediatricians won't follow them after that time.
I have one more question. I'll shut up after this. I asked too many questions, but this is a mechanistic question. I don't have any basic science background, but when I order patients genetic tests for idiopathic pancreatitis.
Yeah, you know what? Can I say something? I apologize. I actually have to be in a meeting 1 minute ago. The problem with Zoom meetings, right? I've got to go into my next Zoom meeting. Thank you all for, I'm sorry, maybe we could deal with that question offline. Thank you all for listening to this discussion.